Good evening, everyone. I'm a Hong Kong private urologist. Today, I would like to talk about physiology, initial assessment, and screening of male infertility. Infertility, we need to define the infertility. That means the inability of a couple to achieve pregnancy with timed unprotected sexual intercourse at least 1 year. It can be primary or secondary. Primary means patients who have never conceived. Secondary means the patient has previous pregnancy but failure to conceive subsequently. For the cause of the infertility in male, we can categorize into three causes. First, pre-testicular, second, testicular, and the third is post-testicular. So the pre-testicular cause is quite uncommon. It's only about 3 to 5% of the male infertility. So as you can see, either it is hypothalamic disease or pituitary disease. While recently more and more people using exogenous hormones for their physical build-up. So as you can see, more and more testosterone will cause inhibition of the hypothalamus and with pituitary hormone secretion, and therefore will inhibit the production of sperms. So exogenous testosterone is a contraception of male fertility. So the testicular cause of male infertility can be either chromosomal or non-chromosomal, while the varicocele is the most common cause in this category. It can be up to 17% of the male infertility. So the varicocele means it is due to the incompetent vein valves in the scrotum, which the blood can be refluxed into the scrotum and causing the increase in temperature in the scrotum, which will result in decreased sperm count. So varicocele is very common in men with primary infertility and more common in the secondary infertility as well. On the physical examinations, we can see the dilated veins under the scrotal skin. On ultrasound, we can show dilated varicose vein, which is more than 2 to 3 millimeters in diameters. On Doppler ultrasounds, the Valsalva maneuver will show the Doppler effect, which is very diagnostic of varicocele. The treatment of the varicocele, we will use microscopic varicocelectomy to selectively ligate the veins and preserve the testicular artery. For the post-testicular cause, the blockage of the ductal system, either congenital or acquired, is quite common. If there is ejaculatory duct obstructions, in the old days we would do a transurethral resection of the ejaculatory duct to deobstruct the ductal system. Nowadays, we will do a minimal invasive transurethral seminal vesiculoscopy by a thin URS through the ejaculatory duct opening. Sometimes we need the laser incisions to open the ejaculatory duct, and the scope can go into the seminal vesicle to have inspection. If there is hemospermia with evidence of inflamed seminal vesicles, we will use the gentamicin solution to flush the seminal vesicle to kill the bacteria, or if there are stones in the seminal vesicle, we will use laser to do the fragmentation of stone. So this is the picture of transurethral seminal vesiculoscopy. That's TUSV. We call it 經尿道精囊內窺鏡. So after we go into the seminal vesicle, on the right side we can see the seminal vesicle with stone. So At the end, we use laser to fragment the stones and gentamicin solution to clean the seminal vesicle and kill the bacteria. The duration of marriage and infertility is important. Any past conception with the previous partner, previous fertility investigations and treatments received, the sexual history for the frequency of intercourse, the libido, the erectile function, and ejaculation is important, and also the lubricant usage is also need to be noticed. For medical history, we need to take notice of diabetes mellitus and hypertension, liver disease if the patient is taking long-term oral exogenous testosterone. Repeated respiratory disease and high fever may indicate the patient's underlying cystic fibrosis. Medication history and duration, history of urinary tract infections or sexually transmitted disease which can causing the blockage of the ductal system. Recently, research have found that COVID history may need to consider which can affect the hypothalamic pituitary gonadal axis dysfunctions end up with lower testosterone. For the surgical history, we may need to consider whether there is any history of vasectomy, testicular surgery for mesenteritis, varicocelectomy, and hydrocelectomy, inguinal hernia surgery, which may cause the obstruction of the vas deferens in the inguinal region, sympathectomy, prostatectomy, bladder neck operation, which will cause the retrograde ejaculation, urethral strictures, and penile surgery for hypospadias that may cause the difficulty of ejaculating the semen into female vagina. For the developmental history, we need to know whether there was mumps or viral disease of the testes in the past, any scrotal injury, any testicular torsion, any treatment for the testicular multiscent, and an age of treatment, puberty and its onset, and also the sexual development. For the occupational history, we need to know whether the testes are exposed to the heat, toxins, or carcinogenic dyes, substance abuse, either cannabis, marijuana, or any exogenous testosterone. So nowadays, body buildup is very common, and the patient may have the history of androgen misuse or androgen abuse, which without the medical indications to use exogenous testosterone, either for physical performance to increase the strength, endurance, and the recovery from the sports, and also for the physical appearance with increased muscle mass, and also sometimes occupational usage for some security staff, police, or armed forces. So the retrograde ejaculations is quite common, which means it is the total or partial absence of antegrade ejaculation due to semen entering the urinary bladder via the bladder neck. The patients may experience normal or decreased orgasmic sensation, while the retrograde ejaculation is benign, but it may impair fertility. So the cause of the retrograde ejaculations can be neurogenic, either by the spinal cord problem, multiple sclerosis, or diabetes. Urethral stricture, also sometimes the drug may affect, for example, the alpha 1 blocker, any SSRI, that is the antidepressant, endocrine problem like hypothyroidism or hypogonadism, bladder neck incompetence after surgery, especially TURP. So the diagnosis of retrograde ejaculation is to show the presence of sperm in post-ejaculatory urine by a special preparation. For any pain after ejaculation can cause the discomfort and severe pain in the penis, scrotum, or the perineum. So the underlying cause may be calculi in the seminal vesicles, sexually transmitted disease, prostatitis, or BPH. So next one is the hemospermia, which means the blood in the ejaculate. Hemospermia can cause anxiety in many men, which in return causing psychological erectile dysfunction. Many causes can cause hemospermia. It can be congenital and quite common due to the inflammatory cause with seminal vasculitis, and also because of obstruction with the calculi in the seminal vesicles. Seldomly is related to any tumor. Some of the vascular hemangioma in seminal vesicle, trauma or iatrogenic cause, or the systemic cause. So in the case of recurrent hemospermia, that means the hemospermia cannot be resolved by 4 weeks of quinolone. That may indicate underlying seminal vasculitis, seminal vesicle stone, or rarely malignancy in the seminal vesicle. Then we may perform a transurethral seminal vasculoscopy, that is a TUSV, to clear the seminal vesicular stones and using the gentamicin flush of the seminal vesicle to clean the seminal vesicles, and therefore with a better environment for the sperm to survive. So the commonly used lubricants, for example, the K1 jelly, curry lotion, astroglide, and saliva are associated with impaired sperm motility. So stress is also very important. It may impair the semen quality, which will result creating a vicious cycle for men experiencing infertility and causing more psychological distress to the male. So we need to measure the testicular volume by using an oxidometer, a sequential series of beads ranging in size from 1 mil to 35 mil. We need to conduct the examination in a warm environment with patient lying on their back. Gently isolate the testis and distinguish it from the epididymis. Then stretch the scrotal skin without compressing the testis. Use the oxidometer to make a manual side-by-side comparison between the testis and the beads. Identify the bead most similar to in size to the testis while making allowance not to include the scrotal skin. So for the asymmetry between testes is quite common and usually not medically significant. Asymmetry is sometimes more marked following unilateral testicular damage by torsion or history of undescended testes, or with the large varicocele. Testes are roughly proportional to body size. Low testicular volume suggests impaired spermatogenesis. Testes which is smaller than 4 mil from mid-puberty are a consistent feature of Klinefelter syndrome. Next is the examination of epididymis. Locate the epididymis which lies along the posterior wall of the testis. It should be soft, slightly irregular, and non-tender. Tenderness, enlargement, or hardening can occur as a result of obstruction, maybe the history of a vasectomy or any infection. This can be associated with obstructive infertility. Cysts in the epididymis are quite common. They are something mistaken for testicular tumor quite commonly. So we need to deeply palpate the spermatic cord to identify the vas deferens, which is around 2 to 3 millimeters. Any nodules or thickening around the vas deferens ends may be due to the history of vasectomy. The vas deferens should be distinguished from the blood vessels and nerves. Absence of the vas deferens is a congenital condition which called cystic fibrosis, associated with low semen volume and azoospermia. On examination, we have to examine the chest to rule out the presence of gynecomastia, which is an excessive persistent development of benign glandular tissue, evenly distributed in a subareolar position of one or both breasts. It can cause soreness of the breast and also embarrassment. It's common during the puberty but will resolve in later adolescence. Causes include the increase in estrogen, low testosterone, and different medications, marijuana, androgen abuse, or abnormal liver function. So we have to distinguish the glandular tissues from the areolar fat in obese subjects. Rarely, the secondary cause can include hypothalamic, pituitary, and adrenal and testicular tumors, so it can affect the male fertility. Rapidly developing gynecomastia may indicate a testicular tumor as well. In contrast to gynecomastia, breast cancer can be located anywhere within the breast tissues and feel firm or hard. So any abnormality of the penis that may prevent placement of semen as cervical os, that is the phimosis, hypospadias, epispadias, and significant penile curvature. Last but not least, rectal examination is essential. We have to do the examination of the prostate to estimate the size. If it's aplastic or hypoplastics, it can be due to the congenital malformation or significant hypoandrogenism. And the seminal vesicle cannot typically be palpated. If they are palpable, it is abnormal and suggesting engorgement and ejaculatory duct obstruction. So the first investigation is semen analysis. A man can be absolutely considered sterile only when no sperm is present in semen. The substantial range of values for any parameter do not discriminate male sterility and infertility. The semen analysis provides useful information on the status of germ cell epithelium, epididymis, and accessory glands. How to collect the semen? After 3 days of abstinence, we have to collect at least two samples with 4 weeks apart in a clean container by masturbation intercourse using elastic condom or electrostimulation. And the specimen has to be examined within an hour of collection. So there are many versions of the cutoff reference value. We nowadays use WHO 2010 as the reference range. So we have to know the semen composition. It contains the sperm and also the fluid that provide nutritional support and as a media. So most of the semen fluid is come from the seminal vesicles, which is alkaline in nature. The prostate provide about 30% of the fluid, which is acidic. The macroscopic evaluation of the semen comprised of the appearance of the semen, the viscosity of the semen, the volume, and also the pH. So the volume with the WHO lower reference limit is 1.5 ml. The seminal hypovolemia causing the low volume can be due to ejaculatory duct obstruction, hypoplasia of the prostate, and seminal vesicle, as may occur in severe androgen deficiency or the congenital bilateral absence of the vas deferens. In retrograde ejaculation, or sometimes because of the neurological conditions, for example, spinal cord injury, diabetes mellitus, or multiple sclerosis. Sometimes the male BPH medications, for example, alpha blocker, can cause hypovolemia. In the condition of aspermia, dry ejaculate and an ejaculation refers to the condition in which no fluid is discharged from the urethra during the male orgasm. If aspermia or seminal hypovolemia, we have to do the post-ejaculatory urine analysis to identify any retrograde ejaculation. That means the number of sperm in urine nears or exceeds that in the antegrade specimen. We have to do the transrectal ultrasound to evaluate whether there is ejaculatory duct obstruction. Semen hypervolemia with an ejaculate volume more than 5 ml is very rare, but it is proposed to interfere male production by diluting the sperm. So the semen sample is primarily made up of alkaline fluid from seminal vesicles and the acidic fluid from the prostate. The pH of the two fluid combined should be a bit alkaline, that is 7.2 to 8.2 pH. Any pH less than 7 in a semen sample may indicate obstruction in the ejaculatory duct. This results in the absence of alkaline secretion from the seminal vesicle. A high pH could indicate the presence of underlying infection. So on the microscopic evaluation of the semen, we have to look for the round cells, any leukocytopenia, the concentration, the motility, the progressive motility, the morphology, and the vitality. The morphology with different abnormal sperms either have head defects, chromosomeless mid-piece defects, or the tail defects. So these are the round cells, and these are the motile sperm. So for sperm count, it can either be azoospermia or cryptospermia, oligospermia. For for azoospermia, that means no sperm is seen in the semen sample. So then we will centrifuge the sample at 3,000 grams for 50 minutes. We take the ballot for examination. If no sperm is found even after centrifugation, that means it is true azoospermia. But we have to repeat the analysis after 2 to 4 weeks to confirm. If sperm can be found in the pellet, that means it is a cryptozoospermia. That means the sperm is less than 100,000 per mil. So for sperm density, the WHO lower reference limit is 15 million per mil. Any specimen less than this density termed oligospermia. Cryptozoospermia means sperm is so few as to be difficult to reliably measure. A man with single semen sample demonstrating 10 millions per mil who has no difficulty impregnating his wife may not be oligospermic, while one with small testes, elevated FSH and density on several semen analysis ranging from 20 to 25 million per mil may be reasonably considered oligospermic. So for the sperm motility, the lower reference limit is 40%. For sperm motility, it is assessed optimally within 30 minutes of liquefaction and refers to the percentage of sperm observed with defined motion. So progressive motility should be more than 32%, and the sperm which doesn't move is immotile sperm. Low motility is termed astenospermia. It has three categories. Grade A means progressive, grade B means non-progressive, and grade C means immotility. So the sperm morphology, the reference range according to WHO strict criteria is more than or equals to 4% of normal forms. Most laboratory quantify morphology using the WHO guidelines or the Kruger's strict criteria classification. An overabundance of abnormal form is termed teratozoospermia. If the acrosome fail to form, the sperm will have small, round heads. It's a disorder referred to as globozoospermia. So for the sperm vitality, vitality refers to the portion of sperm that are metabolically active living cells. If near or total acinospermia is observed, to discriminate whether the lack of motility is a result of cell death or dysfunction of the molecular process involved in the sperm motion. A method of assessing sperm vitality is called hypoosmotic swelling test on the right side. When incubated in hypoosmotic medium, the tails of live sperm with unimpaired membrane swell within 5 minutes, allowing for identification of viable gametes. Necrospermia is the term to describe a large number of non-living sperm. So the fructose is the energy source for sperm motility. It's present in all semen specimens except for males with congenital bilateral absence of vas deferens in cystic fibrosis mutation or bilateral ejaculatory ductal obstruction. A qualitative fructose test is usually performed on azoospermia specimens and with a semen volume of less than 1.5 ml. We can identify different conditions by the profile of the hormone. Low testosterone with high FSH means there is possibility of primary testicular failure, especially in Klinefelter syndrome. For the low testosterone level with low FSH means there may be a hypogonadotropic hypogonadism in Kalman syndrome. In low testosterone, low FSH with high prolactin, that means there is hyperprolactinemia that may cause an erectile dysfunction. For genetic evaluations, first of all, we need to check the karyotype. And Klinefelter syndrome with the karyotype of XXY is one of the most common chromosomal disorder in the testicular course. The patient will have a taller than average height, reduced facial hair, reduced body hair with gynecomastia, then feminine fat distribution, osteoporosis with a small testis, usually less than 4 mil, and also varicose veins. So next genetic evaluation is the Y chromosome microdeletion. It is PCR-based assay. It is to identify the AZF azoospermia factor region, including the A, B, C microdeletions. It should be done in men with azoospermia or cryptozoospermia of less than 5 million sperm per mil. And the microdeletions of AZFA, AZFB have low probability of retrieval. Therefore, micro-TC is not suggested. For AZFC, micro-TC can have a retrieval rate up to 67%. But in AZFC carrier, oligospermia can progress to azoospermia. So the next genetic evaluation is the cystic fibrosis transmembrane conductance regulator gene mutation. 98% of males affected with cystic fibrosis are infertile. The chromosome 7q is where the cystic fibrosis gene located. Clinical features in male with cystic fibrosis infertility is due to atrophy, fibrosis, and congenital absence of vas deferens. So the congenital absence of vas deferens in cystic fibrosis comprise of 1 to 2% of male infertility and 6% of obstructive azoospermia. So for the diagnosis of congenital bilateral absence of vas deferens in CBAVD, the semen has low volume, low pH, and fructose negative. We can do a transrectal ultrasound to look for the presence of seminal vesicle. Renal ultrasound has to be done if either one side or both sides congenital bilateral absence of vas deferens because they may have renal agenesis. The CFTR gene testing is required, and also we need to test the partner as well. The final genetic test is the DNA fermentation index. For those who are fertile, should be less than 25% of DFI. Factors that can cause DNA fermentation in sperm are advanced paternal age, inadequate diet, drug abuse, tobacco use, environmental factors such as pesticide exposure or air pollution, varicocele, systemic diseases, and genital inflammation. So in conclusion, what urologists can help in male infertility? We can perform MESA or micro-TC to obtain sperms in those patients with non-obstructive azoospermia or oligospermia. We can perform Peyronie's plication if the patient has curvature on erection. We can perform microsurgical subinguinal varicocele repair if the patient has severe varicocele causing male infertility. If patient has history of vasectomy, we can do the reversal. If patient has severe phimosis, we can do circumcision. And finally, if the patient has obstruction of the ejaculatory duct with seminal vesicalitis and stone in seminal vesicle, we can do a transurethral seminal vasculoscopy. Thank you.